Hey everybody, it's Karen Anderson here with Aortichope and Greg Aaron Greenberg. It looks like it's just the two of us for today reading the week in review from last week. And yeah, a lot of exciting things because we are in the throes of Aortic Disease Awareness Month. And why do we call it a month? Because there's way too much information to try to get it all out in a week or even in one day. So hope you're enjoying all of the informative posts that we're providing for you on Facebook and on our website, as well as some contests sprinkled in between and live events. I've heard nothing but amazing things about the live event that Dr. Udelman was able to do with us. That's really has come back with some very positive reviews. So if you have a chance, check that video out on our YouTube channel. And while you're at it, like and subscribe so that you are notified about events like this and all other things that happen. Greg Aaron Greenberg.
Yes. So, like you said, this is our week in review. And if you're new to us, we are covering the previous week's posts. So, this will be the post starting the week of September 6th. And we start with Monday, and it was obviously Labor Day. So, we wanted to thank everyone that works hard every day in whatever job you hold, or if you just work hard at surviving. We recognize that many in the community are no longer able to work because of aortic disease. However, don't dismiss the work that goes into getting up and living your best life every day. We will have some interesting quotes here. It is only through labor and painful effort, by grim energy and resolute courage, that we move on to better things. And that's a famous quote by Theodore Roosevelt. Our next quote comes from Albert Einstein, who ironically passed from an abdominal aortic aneurysm rupture. And his quote was, 100 times every day, I remind myself that my inner and outer life depend on the labors of other men, living and dead, and that I must exert myself in order to give in the same measure as I have received and am still receiving. I always like that quote. And then we have a quote from Mahatma Gandhi. It's, if you can no longer participate in a career or workplace, the best way to find yourself is to lose yourself in the service of others. I think, which we definitely understand a little bit here at Aortic Hope. And then we have the famous Aortic Hope quote that was coined by a certain lady that's on this broadcast with me. And it is, don't just survive, strive to thrive.
Which is probably the best.
Note, my dogs have something to say.
Yeah. Good stuff. Good quotes.
Yes, it is.
What'd you do for day? Did you do anything fun? Did you barbecue? Did you just hang out?
I did nothing. It was just a hangout day. I know you were away. So
I was celebrating my husband's 60th birthday, which was the day before. It seems so weird to say, but we had a lovely time. Eventful. Yeah. It's good. Don't lay out with sunglasses on or you end up with like raccoon eyes. It's just throwing it right out there.
It's a good look though. It's a positive look.
Bright-eyed. I look bright-eyed and bushy.
I think the important thing, like what we were talking about there, is that we know in this community that a lot of us are not able to work full time anymore. And I don't think that has to weigh so heavily on your mind that you aren't contributing something. You know, whether you're contributing to your own household, whether it's your local community, whether it's a nonprofit like us and you're helping out there. There are plenty of things that can do that can make you feel like you are still of service. That's just my take. I know I was definitely struggled with the idea of not working full time, but
it was a struggle for me in the beginning. It is so not a struggle for me anymore. Almost 7 years later. It's funny. I'm living through the eyes of my son who recently graduated. And, you know, he's telling me, you know, Sundays aren't even fun because I got to wake up for work the next day. Been there, done that, kid. No, but yeah, Aortic Hope keeps us very busy, obviously, and that's 100% volunteer work. But if you your life is not your job. A job is something that creates the ability to have some income to do things within life. But that idea of a job can look many, many different ways. And we don't get paid for that in money. Volunteer work can be a very lucrative position in that it gives you the feels, and that is just, you can't put a price tag on that.
Exactly. So, but, basically what I had said, like you can feel like you're contributing and you're of use.
We have a job for you guys out there. If any of the survivors that watch this would like to contribute, any of our Hope ambassadors want a chance to come on board with us and be a panelist, we'd love to have you. So there you go. There's something.
Perfect. Yeah, that's perfect. You can come join us and be a part of these discussions.
Yeah.
Okay, so we're going to move on to Tuesday, since this is a shock-full week. And it's a doozy.
Well, we had aneurysms last week, which made, first we had Aorta 101, and we had a chance to share with everybody what actually is the aorta and explain that this is not heart disease. This is a separate vessel from the heart, totally separate. So we focused on that. And then I believe you guys, while I was gone, you talked about aneurysms. So it makes sense to move into what can happen that we don't want to see happen.
Right.
One of the reasons could be if you had an aneurysm, and that would be your topic Tuesday.
Yes, the topic Tuesday, though, still goes back to the idea of that thoracic aneurysm. And so we'll be sharing you with information related to the thoracic aneurysms for Aortic Disease Awareness Month. And a big thank you to the Society of Thoracic Surgeons for celebrating with us and not only sharing with the community information about aortichope during this month, but also for having a website link dedicated to patients that is filled with incredibly easy to read information. You can click the link below, and across the top, you can click on patients and then click their patient website, and you can get all the information. Once again, we will cover that a thoracic aortic aneurysm is an expansion or ballooning of a section of the aorta within the chest, which is also referred to as the thorax, that slowly degenerates. The aorta, the body's main blood vessel, starts at your heart and extends all the way to your pelvis, where it branches towards your legs. The larger the aneurysm, the higher the risk it may rupture, leading to damage of the aortic wall and bleeding that could cause death. As listed in the patient guide of the Society of Thoracic Surgeons website, many factors potentially can contribute to the development of an aortic aneurysm, and it's often difficult to determine the exact cause of them. Some of the most common conditions associated with aneurysm formation are congenital or genetic causes for a weakness of the artery wall. That tends to be present from birth. Changes in your aorta due to advanced age. There is just an aspect of living life that is going to potentially change your aorta. Then there's connective tissue disorders such as Marfan or Ehlers-Danlos syndrome, as well as others. I don't want to leave out Loeys-Dietz or anything like that. There are specific things that can cause inflammation of your aorta, a hardening of the arteries, which is known as arteriosclerosis, where fat, cholesterol, and other substances, referred to as plaque, clog your arteries. There are cases of injury from falls or chest traumas, such as motor vehicle accidents. There are untreated infections, such as syphilis or salmonella, that can actually advance and cause issues with the aorta. But I would say some cases, but the majority of cases they seem to be finding now, aneurysms run in families and are classified as familial. So several members of extended families may be affected by aneurysms in different locations, and that can be done with or without any known genetic component, which is important to understand. I will tag you in for this last part.
Well, and you know what? Going over this part here is a part that I know you and we get a little frustrated because more than likely your thoracic aortic aneurysm is not going to have any symptoms. I mean, it would need to be really large relative to the size of your chest cavity and wall in order for it to create symptoms. Most people find an aneurysm not because they went in due to symptoms, but for something else completely unrelated. And then once they find out they have it, all of a sudden, now you start finding that you're having symptoms. So I'm not here to say that you are or not experiencing symptoms, although I think the community at large finds it interesting that the symptoms aren't there prior to diagnosis in most cases. But if you are going to have some symptoms, it could be the ones that are listed below, and that could be hoarseness or trouble swallowing. You could feel a little bit of, you could have some swelling in your neck, pressure in your chest or upper back. I guess it could cause nausea or vomiting and a rapid heart rate from just having the aneurysm.
Right. In theory, they don't necessarily, the aneurysm itself doesn't cause pain, but that's not to say that it can't put pressure or cause things
on
that
nerves
might show up as a symptom.
Right.
But
right.
like you said, it's a wonderful little enigma in our community. There are so many of us that dissected that never had a complaint or an idea that anything was going on until the moment of dissection.
Well, and here's some real hardcore proof. I don't have the stats, of course, because I would not retain those. But the study is being published now from Dr. Udelman and his staff at Maimonides Hospital. And, you know, typically if a patient goes in because they have pain in their chest or they might have pneumonia and they want to do a CT scan, this was even before COVID. If there's anything that shows up in that thoracic area, a thoracic surgeon is going to be notified and be brought in, which is wonderful. I don't know that this happens in every hospital, but if something major is found, the coordinating doctor would be notified. So during COVID, it was happening so often, these CT scans, because last year, there was just so many patients having them done that he noticed a drop in receiving the scans. So he went in on his own and requested to see the scans of like 1,500 patients. And it was shocking to see how many of those patients had an aneurysm of 4.5 or larger. And of that percentage, there was a nice amount of people who were at 5.5. And once COVID passed, they're going to be facing surgery. So they did not come in there because of pain of an aneurysm. They went into the hospital due to COVID and had no symptoms before. So walking around every day, people have high blood pressure and they don't know it. And we're talking blood pressure in the 200s over high hundreds. So blood pressure is a huge problem in this country. So just think about how many people are walking around with aneurysms and they just don't know it. So, but if you do, like me, I feel my blood pressure when it gets around 138. Not many people feel their blood pressure when it gets high. I did not prior to my event. I do now. So I'm sure there are some people that are symptomatic with their aneurysms, and this gives you an idea on what some of those might. So when I have symptoms, when my blood pressure gets high, I tend to feel, I guess if you had a rubber band around the tip of your finger and that blood starts to pull and you feel pressure, I feel the sensation, that same sensation, or as if I were hanging from monkey bars upside down when all the blood rushes to your head. I just feel that all the time once I hit around 138. So to me, it's very uncomfortable. Sometimes my ears will pound, things will pound, and I know right away when I take it, it's going to be high. And it's not as though I had anxiety and now I feel it and then I see it's high. It just becomes high and then everything else happens afterwards. So that's what I feel. Not everybody feels when their blood pressure gets high. It's not typical.
Right. And there are some that just write it off. I mean, a huge proponent, like you just said, of symptoms with high blood pressure, a lot of people get a headache and they just don't really realize it. It tends to be the base of the skull, the top of the neck, and there tends to be a headache or pressure there, and that is another sign. That tends to be a headache that is caused by hypertension or elevated for a specific reason at a given time. But if you're experiencing those regularly, then I can probably tell you that your BP is a little bit high on the regular. Yep. But we will move on to our Wisdom Wednesday.
Oh, wait, there's one thing I want to talk about when it comes to the dissections that we did not get to. So one of the greatest analogies or description of a dissection was by Thomas McGilvray. I'm so sorry if Thomas McGilvray happens to see this, but he's a cardiac surgeon and chief of cardiac surgery and thoracic transplant surgery at Houston Methodist Hospital at the time of this being printed on the website. And he used a paper towel analogy to describe aortic dissection. And because we always use a garden hose, and what happens when you've been using it with high pressure year after year, eventually the outer edge might bubble. And that's what we use to describe an aneurysm. But here he describes aortic dissection as if you think about paper towel wrapped in plastic, you just picked it off the shelf. Well, a tear would occur in the cardboard tube that's in this roll, which would cause the blood to plow through both the cardboard and the paper towel. So if you picture your paper towel and you ripped some of the cardboard and there was blood or water, anything flowing through that, it's going to rush through the rest of that sealed cardboard tube and into the layers of the paper towel, where it would actually create a false channel, a channel where there was not one. So the blood would either be contained by the plastic wrapper, or that plastic wrapper with enough pressure and enough blood would eventually burst, and that would be your aortic rupture, which does not necessarily mean imminent death, as Dr. Udelman explained. If it's small enough, blood could coagulate and you can buy some time. But I love that analogy because if we could rush water through a paper towel and somehow it was sealed, at least on the outer edges, it is very interesting to visualize it like that. So hopefully that helps people kind of get an idea on what aortic dissection actually means and what's happening at that moment. Well, that I wanted to highlight. Just saying. Visualization.
Okay.
You missed that. I was pulling you in.
No, it's there. You got me, my little ASMR tricks.
Yeah.
Right now, I'm just trying to figure out if you and I are on the same script or if I'm in a different week.
No, Wisdom Wednesday, abdominal aortic aneurysms. I think that popped up because we didn't hit the abdominal. This was strictly thoracic. We had aneurysms and we had dissection, and then we moved into the abdominal area. So yes, that is correct. Okay. Where we talked about
I just wanted to make sure. Yeah. And so we move on to Wisdom Wednesday.
And before you get into this, what's interesting is remember when we met in this community, how divided the community was, where the dividing line on the aorta is. And we could never understand why aren't people incorporating abdominal issues, because it's the entire aorta. It's one thing. Why do you stop? And
well, yeah, it was very specific. I mean, that was kind of where,
makes no sense.
We felt in Aortic Hope was talking about it. Like, why would we only address one little portion? Why wouldn't we talk about everything?
Right. Because if you have an issue,
you're right. Like the abdominal people were very specific to abdominal. The thoracic people were very specific to thoracic.
But one can impact the other. It can happen anywhere.
No, and in a lot of cases that we all know that there are those of us that deal with issues on both. There are type A dissections that residually tear into the abdominal area.
Right.
There are plenty of us. You and I are both people that has happened to. Yep. So, that happened on our initial incident. So,
and there are people who tear in the abdominal area, which would be considered a type B, and then tear up.
And then have retrograde tears, like you said. Right. And all of a sudden now they're tearing upwards in type A. Yep. So, I mean, it's, and there are people that are addressed in both ways, as somebody
it's part of that whole aorta, hence the picture. So Tell us all about it.
Okay. So Wisdom Wednesday. And it's all about, as you can probably guess, because we talked about it, abdominal aortic aneurysms. And while not necessarily as life-threatening or uncommon, AAAs, as commonly known, can still pose issues for the body. Check out the information titled Abdominal Aortic Aneurysm, also called AAA, by Dr. Michael J. Singh, which the link will be provided. When the wall of a blood vessel weakens, a balloon-like dilation called an aneurysm sometimes develops. This happens when most often in the abdominal aorta, an essential blood vessel that supplies blood to your legs. And I will add also to a lot of your abdominal systems or organs like liver, kidneys. Those are all branches that come off of your abdominal aorta. It is much more common in thoracic. It's about 200,000 people in the U.S. are diagnosed with an abdominal aortic aneurysm every year. A ruptured AAA is the 15th leading cause of death in the country and the 10th leading cause of death in men older than 55.
And I do want to mention to that, that scan is covered by all insurance for men that I believe are 60 and older. And I think that they're working on a plan to reduce that age, lower the age, and start to include women because they, of course, are learning. This is not strictly found in only men. But just for people listening, if you have a family history, if you're a smoker, if you have diabetes, if you're overweight, if you have high blood pressure, you can have a scan of your aorta, your abdominal aorta, covered by insurance. Continue.
I will also add that ultrasound of the abdominal aorta, while not perfect because it only shows you the view of the abdominal aorta, also is not a horribly expensive scan to have done out of pocket. There are a lot of places that offer it in a little healthcare package that might be a couple $100 that includes an abdominal ultrasound that can look at your aorta. So that is, even if it's not covered per se, if you're concerned about it, or if you think or you're scared, you can have it looked at. Even out of pocket cost is not that high on it. But again, the caveat is it only sees a small part of your abdominal aorta. It does not give you a clean bill of health for your whole aorta. That is only done with wide scan imaging like a CT or an MRA. But family history is important, and that's the key to this. Aneurysms run in families. If a first degree relative has a AAA, you are 12 times more likely to develop an abdominal aortic aneurysm of your own. Of patients in treatment to repair a AAA, 15 to 25% have 25% have a first degree relative with the same type of aneurysm. For more information about abdominal aortic aneurysms, symptoms, and causes, click on this link provided by that brings you to the Mayo Clinic article about such. So,
and something else is David watching us? Hi, David. Thanks so much for joining us. If you have any comments or questions, please put them in the comments section and we'll be sure to address them. I do want to say it's one of the other pet peeves that I know you have and I have had too in the community is AAA, abdominal aortic aneurysm. Not going to be acknowledged and recognized as ascending aortic aneurysm. That is going to be your TAD, your thoracic ascending aortic aneurysm, or your TAAA. There's a big difference. So if you're referring to your abdominal, it's just AAA. If you're referring to your ascending, it would be throw a T in front of that. So we know that it's in the thoracic and it's the ascending part of your aneurysm.
Yes, in the old days, they were potentially ascending aortic aneurysm was how it was referred to and diagnosed. So obviously, you had AAAs, but as anyone can tell in the community, sometimes someone throws out that AAA, and it's very difficult to give them advice because which are you actually saying AAA as in stomach? Because everything that they seem to be telling you sounds like it's thoracic, and that's where you can kind of get explanation for, because it's hard to give the right advice or try to steer people in the right direction of what they need to look for or be concerned about when we don't always have the right information.
And the other thing to understand is your abdominal aneurysms tend to grow at a much slower rate than it would be your thoracic ascending because it's so much further away from the heart. So I know personally, my father has had one for many years. It doesn't grow. But if you have one in the ascending, it is so close to that high volume of blood that's being pushed out. So that's going to be affected, which makes it definitely more imminent for danger and potential for dissection versus the abdominal. I mean, everything is still very important and needs to be followed, but it is further away. So you're not having that same volume push. Don't you love all my visuals? Really?
Woo! Yeah, no, I mean, it's important to understand that AAA is much more likely, the abdominal aneurysm is much more likely to be characteristic of like your life. like you've reached this age, they kind of can happen. Diet, smoking, certain aspects, arteriosclerosis, that tends to lead towards a lot more of the abdominal issues. Um, and for others, you will see a lot more that happens through the abdominal aorta. If it's happening at a younger age, that tends to be a little bit, it seems to be a little more linked, I would say anecdotally, to the connective tissue areas and stuff like that. Or, God forbid, in the situation of the pregnancy related dissections, can be type B, lower abdominal dissections from time to time, stuff like that.
Mm-hmm.
So we will move on to our Thursday.
Thursday is a great one. They're all great, but this one's really interesting.
Yes.
Are we there?
This is all about dissections.
I would like jumped ahead. I was totally ahead on that whole dissection part. This is where I wanted to talk about it. I didn't realize we were still hitting thoracic aneurysm. My apologies for being.
Oh, it's okay. That's why I was asking. I'm not sure if we were on the same script. I was afraid I might have the wrong week.
No, that's all right. Go ahead and give a description of what that dissection means.
Now, this is from the Society of Thoracic Surgeons.
Yep.
Although aortic dissection is relatively uncommon, it is the most frequent emergency related to the human aorta. It affects approximately 3 people out of 100,000 each year, most often in men with high blood pressure in their 60s and 70s. That is still a true fact, the 60s and 70s. We are just, anecdotally, we are seeing a lot more people that are younger survive their initial emergencies than you might have seen 20 years ago. And that's why I think we see so many people in the community that are below that age, but it's still more prevalent in that age group of 60 and 70-year-olds and still skews a little bit more towards men.
So don't read what it says online that you have a 5-year lifespan after having a dissection, because back in the day, they only really followed individuals who had a known syndrome like Marfan's, Loeys-Dietz, vascular Ehlers-Danlos. So they were receiving the follow-ups, and they only represent about 5% of the population. So the other 95% of individuals who had this happen to, once they were fixed, it was like, go home, live your life. And there really wasn't that high degree of follow-up that we see now, that we've been seeing for many, many, many years. So this is why, as the first real generation of true follow-up, people are living a lot longer, because they've realized that we do have subsequent issues and events that might require some form of intervention. So don't read what you see online.
Right. Those statistics are scary, but perfect example, it applies to those men in the 60s and 70s that might have had other comorbidities. And if I was 75 and dissected and survived it and got 9 more years, you would say, oh, okay, I lived a healthy life. I lived to 84. But yet I statistically fall into that category of didn't make it 10 years post dissection. So, like you said, it's very skewed. Do not trust any of those numbers that you read. Like Karen said, we are the first generation where all this is really working out. And like Karen said, we're being monitored and everything is taking steps. Surgery has come 10 times further. The initial diagnosis has come 10 times further. So surgical outcomes are better. Everything is better than what those statistics showed. Not to mention that they were following people for 10 years, and most of those statistics that you will find online were studies that were published in 2012, 2013. So that was going back to dissection cases in 2002. And as we know, it's a whole different, year by year is a whole different medical landscape, but especially in the world of aortic disease and the specialty that surgeons have with the aorta now. So what is aortic dissection? Like Karen said earlier, occurs when the innermost layer of the aorta, your intima, tears and blood surges through the tear. Younger patients with inherited connective tissue disorders, such as Marfan syndrome, and patients with bicuspid aortic valves, which is 2 leaflets on the valve instead of 3, are also more likely to develop an aortic dissection. Karen used the analogy earlier. Would you like to state it again about the roll of paper, or should we just let that go?
Well, and as it describes here, so you've got your 3 layers. Your outermost layer would be the plastic wrapper. The next layer in would be your actual paper towel, and the inner layer would be that tube. And so if you tore the actual cardboard layer, that would create a false channel. And if with enough pressure, that blood could flow through all of those paper towels and actually cause a small hole or a rupture on the outer layer, which is what we want to avoid.
Yes, like Karen said,
and there
using
it is.
that paper. Now that's ultimately what you want to avoid.
Yep. There's a million reasons why people get these. So many, I mean, there's not a million, but there's many reasons. And I think people, they always thought that it was just like we said, Marfan. That's why you're going to have an aortic dissection or a syndrome. And that's not necessarily the case. This goes a lot larger, a lot more other reasons.
Right. But there is a thought that they are familial and that there is a genetic cause. It's just a question of whether or not they have pinpointed said cause. Mm-hmm. So right now, initially, way back when, it was those known syndromes, and everyone thought that aortic dissection was related to those syndromes specifically. And obviously, as the years go on, we learn that they aren't. They do put you at higher risk for dissection, but they don't make up the majority of the dissection community. Majority of dissection community will probably test at this point in 2021 as an unknown potential genetic cause. Mm-hmm. And the reason why they'll say genetic cause is because it will potentially run rampant through a family. You'll see a family history of something that is linked to it. But the genetic test comes back negative for anything known. But it is important to note that there are other reasons, like this says, besides genetics, there is chronic high blood pressure that can cause this, which can be genetic as well. There are a lot of families that just where blood pressure runs high in that family. High cholesterol can help lead towards aneurysms and dissection. And then, of course, smoking, illegal drug use, unfortunately, with stimulants and stuff like that, can lead to this. And of course, in a very small percentage, trauma, such as a blow to the chest or car accidents, stuff like that. And
this is a lot of information in this post, which is on our website.
It is. I mean, we've talked about, we've mentioned some of the syndromes. There are specific genes that are known. Some of the syndromes, such as Marfan, Loewy-Dietz, Ehlers-Danlos, they're starting to have classification of its own, which familial thoracic aortic aneurysm dissection, the FTAAD class of itself. And there are other ones as well, such as Turner syndrome, ankylosing spondylitis has been known to be tied. A lot of different inflammatory diseases are known to be somewhat linked, whether or not they directly cause or if they just are a contributing factor to it happening. A bicuspid valve tends to be a marker for certain connective tissue syndromes. But even on its own, if it doesn't come up with any other gene, it's going to be associated with valve problems, potential root aneurysms, and ascending aortic aneurysms. Those aneurysms have the potential to result in aortic dissection as well. Chronically uncontrolled high blood pressure, like we stated, can put stress on the aortic wall over time and can lead to aneurysm and dissection. Patients with blood vessel disease related to years of high blood pressure, high cholesterol, or smoking can develop a calcification or ulcer of the aorta that may become the site where dissection occurs. Like we said, it can also dissect or rupture from trauma, such as high-speed motor vehicle accidents or a fall from a significant height. Additionally, cocaine and methamphetamine use can also increase the likelihood of aortic dissection. I will add that my energy drink habit did not help. My doctors basically had referred it to very similar doing what cocaine and other stimulants would do to your body. So I'll just throw out that warning. Then a lot of people ask, how do I know that I have an aortic dissection? The most common symptom is severe pain, often described as a tearing or ripping feeling in the chest. The pain may radiate to the back or move down towards the abdomen. Because aortic dissection can affect the aortic valve or blood flow to any of the blood vessels that branch from it, you can also experience various other symptoms that would not necessarily lead you or your physician to suspect a problem with the aorta. If the arteries that supply blood to the heart are affected, you can have chest pain that may seem like a heart attack. If the branches of the brain, which are the carotid arteries, are affected, you would have symptoms of stroke, such as difficulty with speech, inability to move one side of your body, or a loss of consciousness. If the branches to the arms or legs, subclavian or iliofemoral arteries are affected, you can develop numbness, tingling, or pain in your arm or legs, or inability to move your arm or legs. If the artery or your intestines, the superior mesenteric artery, is affected, you may have nausea, abdominal pain, or bloody bowel movements. If the arteries to your spinal cord, intercostal and lumbar arteries, are affected, you may not be able to move your legs. Blood flow to the liver and kidneys can also be affected. This would not necessarily cause symptoms, but would show up in laboratory studies from a blood sample. Additionally, if the aortic valve becomes severely leaky because of the dissection, you might feel like you can't breathe. But remember, you can always go to the Society of Thoracic Surgeons website and find so much valuable information under their patient website section, and the link will be attached to this video.
I have so many issues with sections, so many issues with it, because there are many people out there that experience none of that. They don't have any of it. They don't have pain. They just may feel a little confused, but none of those arteries are directly affected. I never started off with nausea or any of those issues initially. And even when those issues happened, I had none of my arteries were affected. All of my arteries are fine. But I think it is one of those things that everybody's going to ask, especially when you find out you have an aneurysm. Am I going to know? The answer is you're going to know. You're going to know that something's not right compared to your normal daily living, whatever it ends up being for you. It doesn't mean you're going to have searing pain in your chest that someone's cutting you open. You might not have pain in your chest at all. And this is one of the problems that Think Aorta is constantly trying to address, because we go in with such different symptoms, and we want doctors to understand that if anything seems remotely out of the ordinary, checking blood pressure on all four, in your ankles, in your wrists, in your arms, if you have a difference of pressure, it should lead you to want to go ahead and just get that definitive CT scan result to determine what's happening, because we all present somewhat differently. There is not a standard presentation as they were taught back in the day. So, and just because you have this doesn't mean that other artery's been affected. It may not be affected at all. It's just your body reacting, all of the adrenaline, all of the hormonal surges reacting to a major trauma, a major injury that has happened in your body. So the bottom line is you will know something's different, because even if you don't know it right away, it will become progressively more, which I can't say worse, it's just going to become more evident that something's wrong. And whenever you're in doubt, go to an ER. If you have an aneurysm and you're in doubt, go to get it checked out. Better off getting it checked out than to just sit back and assume it's gas. But you should go get something checked out if you're concerned, if you're feeling different.
I think the point is, you brought it up. That's it's what obviously Think Aorta is trying to address. And we constantly have used the term before. It's referred to as the great mimicker. It can mimic a lot of different things. So it's always pieces of puzzle. But I think you brought up a really good point with, especially if you have a known aneurysm, that's half the battle. So knowing that you have an aneurysm and relaying that to the doctors should help them get to, even if you're not a classically presenting case like they described or laid out here in the old day of the searing pain or anything like that, they will get to the right test for you to rule it out. And that's the most important thing.
Yep.
Most important thing is getting the right test, either for if it's happening, getting you into surgery, if you require surgery, as quickly as possible, or if you don't, then ruling it out, giving that peace of mind, and then trying to figure out what might actually be going on with you. There are a lot of things, like you said, that it can present in many ways, and there are a lot of things that can mimic it.
Mm-hmm. Hey, Kurt.
Kurt, thank you for joining us as always.
We appreciate your support. If you have any questions or any comments you'd like to add, type them below.
Yes.
All right, we've got another good one coming. What's coming up? This is a big one.
Friday.
This is a big one too. This one we cannot read everything to you because there's just too much information. But there's a really great link in here that will take you to a phenomenal PDF. There was a presentation that was given to us by Dr. Kristen Watson from the University of Maryland that really went over everything that has to do with all of the medications that we take.
And as part of the month, we're sharing you all that information about the medications that are usually prescribed to those of us with aortic disease. And that goes from you just found out you had a dilation and a small dose to those of us that have dissected and might be on more meds. The most important thing is that it's a great tool to start a conversation with your physician in the event you are having any side effects or just general questions pertaining to your medications. Prescription blood pressure drugs come in many classes. There are a variety of classes of high blood pressure medications, and they each include a number of different drugs. So if you click on that link, you can learn about the class of medications and potential side effects. Like Karen said, it was provided to us by Dr. Kristen Watson, who is certified in pharmacology and cardiology from the University of Maryland. For information and reference, we've included generic names as well as the many major trade names to help you identify what you might be taking. If your prescription medication isn't on the list, remember that your healthcare provider and pharmacists are your best sources of information. I can't stress that enough. And it's important to discuss all the drugs you take with your doctor and understand the desired effects and possible side effects. And the most important thing, never stop taking a medication and never change your dose or frequency without first discussing it with your doctor and consulting with your doctor.
So one of the great things about this, I think, was that what it showed you broad picture is how many drugs exist to help with whether it's keeping the sponginess of the vessel, which are your like losartans, your TANs, those drugs, or if it's controlling your actual blood pressure, or if it's controlling your heart rate. So a lot of this, most of it is never discussed with us. We're told, take this medication. And it is important, I think, for us to ask our doctor, what does it do and why? Because there's a lot of medications out there that do certain things, and unbeknownst to me in the beginning, these things do not take effect in 20, 25 minutes like an Advil or Tylenol. Some of these can take 2 hours to start. Some can take upwards of 4 hours to hit full peak, and they can take weeks before they're really, really affecting your body. So if you take it in the morning and then you forget and you take it later in the day, you can't be so surprised if your blood pressure becomes elevated. So that's why it's very important to take them as directed. And if you have a question about what twice a day or 3 times a day or 4 times a day actually means, you should ask. It's also, like Greg said, important not to stop. For instance, if you're taking clonidine, whether it's patch or pill form, you cannot cold turkey that medication because it will give rebound blood pressure. And so your blood pressure can just really skyrocket if you just cold turkey that medication. And the other things that are in this, really, they discuss sun sensitivity, what your side effects might actually be, the conversations you can have to try to take a different medication, but it would have to be out of that classification, because if you're having a reaction to one, you're probably going to have it to another one that falls in that classification. But it's a lot to talk about with your doctor, which is great.
Right. And if you notice those problems, if you have that discussion with them, they are prepared to change up little things in your regimen if there's an issue. And I think that's the most important thing, discussion wise. I think it's also important. Don't be afraid to. I mean, we all talk about Dr. Google and everything like that, but there's a lot of good information by just searching your meds. You will hear anecdotally what people might have as side effects, so you can hear it. But you will also find the most important thing to me, things that are contraindicated with the medication that you're taking. I spoke to it a couple weeks ago about I love grapefruit juice and didn't realize that it was a big no-no initially with my calcium channel uh, blocker that I was on blood pressure med. And then I got really excited a couple weeks ago because I realized, woohoo, I'm not on that drug anymore. I can start drinking grapefruit juice again. Only to find out that the only other thing that it's contraindicated for is SARTANs. So I am back to not being able to take it. Or not SARTANs, statins. Statins is the other one it's not. So I cannot take it. Should not be drinking it again. But there are little picadillos sometimes of stuff that might dictate what you should or shouldn't. Or like you said, possibly it could be going into the sun, photosensitivity with this drug, or something along the lines of that.
Mm-hmm. All that is in this slide presentation when you click the link. So great conversation starters with your doctors.
Yep.
All right. Which leads us to, is that all?
I don't know. We are wrapping up. We have something for Sunday.
Mm-hmm.
And it was Genetic Sunday. And we are talking about the John Ritter Research Program and how they explain Genetics 101 and the risk factors for aortic disease, which is some of the stuff that we've covered before. Genetics 101, genes are the basic physical and functional units of heredity. They are made up of DNA and act as instructions for our body to grow and develop properly. The Human Genome Project has estimated that humans have between 20 and 25,000 genes. They are stored in packages called chromosomes. And genetic syndromes. Genetic syndromes are genetic diseases that affect more than one system. And some of these syndromes increase the risk for thoracic aortic aneurysm and dissection, which we've discussed before. Disorders that confer this increased risk of TAAD include Marfan, Loeys-Dietz, vascular Ehlers-Danlos syndrome, Turner syndrome, and I will add that other Ehlers-Danlos syndromes, not just the vascular variety, have also been known. For additional information, you can click the link that we provide below. It's important to note that if you should decide to not participate in a research program or have genetic testing, that you need to advocate for yourself and your family and make sure that they are monitored and treated as if a genetic condition is known. The same monitoring should take place whether a gene has been determined or not, as most individuals with aortic disease have no known genetic mutation.
Genetic testing.
Oh, go ahead.
I was going to say, this is a big hot topic in the community as well. And I know for me, I wanted to know why this happened to me. I was so angry. I wanted to know. I wanted to protect my son, my sister, see if there was a way to protect my parents. And then over the years, I've realized for me, it's not important, because even if they found something in me, regardless if they do or they don't, they should still treat my family members as if there's the potential for them to have something, and have whatever follow-up testing is appropriate for them without having anything known. And that is different. They're not going to have yearly tests like me. My son's going to have them every 3 to 5 years. So genetic testing is a very personal experience. I know it's very personal with people who might have the BRCA gene. So it's very personal. And there's a lot to think about. When you're being genetically tested, you will have results very quickly, and your information is out there. So if things were to ever change in our insurance system and pre-existing conditions, God forbid, came back, now you have this, well, you may have this potential of opening Pandora's box for your children, for your siblings, for whomever. So you need to think about insurances, life insurance, various things like that. Now, research program is great because it's free. And also to mention some of the clinical genetic testing, if not covered by insurance, usually there's some type of financial aid that they're able to give you. But when it comes to research, and John Ritter Research Program would be the prominent one in the community, though there are others that are out there. It may take a lot longer, if ever, to find out if anything was found. If nothing's found, you're not going to hear back. But if something's found, you will. And they do store your DNA so that as they discover more genes, they, based upon so many factors of family history, they will determine what batches they're going to go back and test. Also, they don't just test it as soon as they get it. They test it in batches of, let's say, about 100. So you might send your material in and you could be waiting a while until they have enough to then begin testing. So it is a much longer process. And if you're having some anxiety about wanting results, research program might not be the best route for you. But if you just want to help participate and help further their studies along and the outcomes, because Dr. Diana Milowitz has done an amazing job in the amount of genes that she has discovered and the connections that she's been able to put together surrounding aortic disease, and you want to be part of that research, that's a great avenue, and you can reach out to them for more information. So there's two schools of thoughts there.
Right. And I would like to add that what you brought up as far as the option of if you didn't go a genetic testing route or didn't get a result, if you're informing the doctors or if your family members are informing their doctors of the key information about what has happened to the family member that might have dissected and such like that, you are basically relaying that big, what should be a warning flag for them to potentially look at you. There's much more known now with everything that we've talked about, with them knowing that it tends to be genetic in nature, that it tends to run in families. So that information alone should always be relayed to both your primary care physician and anything like that, and especially in an emergency setting. Because the last thing you want to say is, oh, I just have this minor little chest pain, but yet, your brother has dissected and you didn't feel like mentioning that to an emergency room worker, where it can be the most pertinent information that you give them all night.
I've heard some people say, well, I think it's important to know if I have a known genetic issue, because then if I have my child tested, I know how to help address issues that may come up with my child. Well, these are not conditions that can be cured. So that's the one negative and downfall. If you find out you have something, you can't cure it. You can't stop it, at least not in 2021. So I thought about that as well. And then what my doctor said to me is, even if we found something in you, your son still has to adhere to the same new weightlifting restrictions, which was so hard to tell a 16-year-old boy, don't lift heavy weights, when their whole being is about, I could bench press 5,000 million pounds. It's very hard to explain, no, you shouldn't. And here's mechanically why you don't want to strain. They're not listening. But the same parameters are going to be put in place whether I had something or I didn't, because we're assuming that at some point probably everybody's going to have this due to genetic if it's not trauma. So those parameters will be there anyway. So again, it goes back to being personal, and as Greg said, just it's all about, as Think Aorta says, think aorta, think family, really sharing your medical history as much as you can find out from your first degree relatives. Maybe I would think not going back past your grandparents. So if it's you want to know your grandparents' medical histories, any sudden deaths, your parents, your siblings, and then you would, be able to get that information relayed for children. So it's sudden deaths, brain aneurysms, any aneurysms, obviously prior dissections, high blood pressure. As Greg had mentioned, the inflammatory issues, while there is not a definitive stamp, Crohn's and colitis or lupus or rheumatoid arthritis causes a dissection, as ankylosing spondylitis tends to have a higher probability of having an aortic dissection. The problem is the inflammatory nature of these diseases, or even Lyme's disease. When you have inflammation markers or CRP markers running consistently really high, your heart is working harder to fix that situation. And the harder your heart works, the greater the chance of developing an aneurysm. And now you've got another chance has gone up of potentially having a dissection with an unknown aneurysm. So just conversations to have and to take them back to your primary care and or cardiologist.
I think that's an important caveat for people to understand, is that it's not necessarily, and that's why a lot of those conditions that you brought up, for you had Crohn's, and you've been very open about that. For me, there's diverticulitis and diverticulosis, I should say, and then the actual infections of diverticulitis. But those, like you said, are inflammatory markers, and it doesn't mean that everybody that ever has this does, but they are going to, not for, I'll use a bad pun, but they're going to inflame the situation. Mm-hmm. It's right there in the word. It is going to make things worse. Like you just said, your system goes into overdrive to fight this inflammation, and that is going to find a weakness if there's a weakness.
Mm-hmm. I think that takes, sorry, go ahead.
That pretty much wraps up the week.
I was just going to say that. We were going to say it at the exact same time. I do want to mention that we have a live event this Wednesday, which is 15th, right? September 15th, yes. At 6 p.m. with Dr. Stacy Fisher, cardiologist. So we will be on our AHTV YouTube channel, where you'll have an opportunity to put in the comments sections any questions you have. If there are questions that you would like to ask anonymously, there will be a link to be able to submit those questions as well. We are participating in the Aortic Bridge Walk for Awareness on Saturday. Members of Aortic Hope will be present there, and Think Aorta, as well as Aortic Bridge, walking maybe across the whole bridge, maybe halfway, who knows, we'll see. But coming together just to have an opportunity for survivors to meet and medical providers as well. I'm thinking that if you registered now, which you can, it's free. They may be out of free t-shirts at this point. I think that cutoff was in August, but if you're in the New York area, we'd love to have an opportunity to meet you. And then on the 19th, we've got participation in the Think Aorta Global Meetup, which is so awesome because this time it's being expanded to not only the additional countries that are joining this global movement, but Aortic Hope will be there. Rock from the Heart will be there. Aortic Warriors will be there. So other nonprofit organizations are going to come on and talk about how they think aorta and how their mission promotes the idea of thinking about the aorta. And then also by Wednesday, we will have our link up for our first bingo event, which is happening on the 22nd. So I'm pretty excited. We have so many other things still happening this month, but that's just what I got to be able to print off.
I would also like to plug, because I will be, after the Think Aorta meetup, I will be hosting a little get-together. Will not be online. It'll be in our private little town hall meetings. But so look for that link coming up, but that'll be more of a meet and greet so that you can meet other members of the community, the aorta community, and come and say hi.
With the name, the whole thing.
Yeah,
nothing heavy.
Sometimes it's good to see the faces, and the smiles, or even the worries with each other. Yep. So that will be a very informal meetup, but I will be hosting that online, and hopefully we'll have a lot of you guys dropping in and see me.
And if you check out our Hope Shops link that's listed right there on the screen, you'll see there's still plenty of time to order some swag to be able to wear and display and start that conversation about aortic disease. And we have so many wonderful and fun little tchotchke things on that tab. And I think that's it. It's a lot.
I think that pretty much wraps up the week.
Well, you had Dr. Udelman right there saying at 4 centimeters, it would be considered aneurysmal. And so, Kurt, if something came back at 4.7, we're not doctors. There's a lot of factors that go into that. Dr. Udelman, if you're still watching and you want to comment on that, we'd love to see it happen. But that, should you be concerned? If you're asking me if I would be concerned, don't ask me, because I'd be concerned that the sky's falling any day of the week. But yeah, those are important questions to have with a surgeon and with your cardiologist. And if you are questioning your responses, there's nothing wrong with going for second opinions, because you got to trust the people that you're working with and the providers you're working with. But I think there are a lot of factors that go into, as Dr. Udelman explained in our prior video, that go into when somebody would be thinking they would have, would look at you as a candidate for surgery. So.
Right. My answer would be, Kurt, that obviously at this point, you have been a member in the community and stuff has happened and you have your doctor. If you're comfortable with them, pick their brain. Pick their brain of how concerned they are about this measurement at 4.7. Is this something new? I mean, because if it was 4.6 in your last scan, then I would say 4.7 would be minimal, if any, growth, and that would not be something to be that concerned about in the moment.
I was at 3.6, and in 6 months I went up a whole centimeter. So I'm a little bit more than a centimeter. So I've got 2 at 4.8. I can't say that I'm really that concerned. I get my scan. If nothing's grown, all I can do is take care of what I can control. I can't really control if this grows beyond the things I can control, which is being compliant with my medication and watching my heart rate if I'm exercising and what the recovery looks like, and just staying in tune with my body and in touch with my doctor and having the follow-up scans. So I'm not hostage to my blood pressure cuff. I just do the things that I'm told to do, and then I wait for my scan. And if I feel anything off, then I make that call. That's all I can control. So I don't know if that helps.
I think it's important to point out that's basically the best way to go about it. And then you address the fight that comes in front of you when it's time to address that fight. I think so many of us in this community, you and I have been here a long time. And I remember when we first got in, you had such anxiety, but you don't see, sure, there are wrinkles that come up for each one of us, and each one of us had it, but I was concerned when I first dissected that I was waiting for the next dissection to happen 2 weeks later and was convinced it was going to. And here I am at approaching 8 years in a week, and that never came.
When I found out my aneurysm grew, I became scared to sneeze. Are you kidding me? I was imploding every time I had a minor cold. I thought this is going to be it. I called the cardiologist and I said, what if I sneeze? What if I cough really hard? Am I going to just blow a gasket? She explained that's not how that works. So,
right. But I think it's important to realize that in the community, I would ask you that question, Karen. Do you see people that just are blowing randomly that we see every day in the aortic community?
I mean, a doctor like Ben would see that more often than we would, but it's so infrequent once you're being monitored. So again, it goes back to just focusing on the things that you can control. And if you have questions in your next visit, then you ask your questions. And one of the questions can be, is there anything else I can do to keep my body in the best position to prevent growth if possible? If growth's going to happen, it's going to happen. So one of the questions is, if you've already submitted to the John Ritter research program, where else can you have testing? I don't think you can just call GeneDx and say, hi, I'd like to do some testing. I do think it is a script when you're dealing with clinical. So I would have that conversation with your cardiologist. Usually they are the ones that would then set up that connection. And some of them, mine is a cardiogeneticist, so some of them can actually do that in-house and get you set up with somebody in the hospital setting. But that's something you want to discuss with your cardiologist. But we are looking into other research programs.
I would say for the newer people, you were getting that option now a lot more in the hospital, potentially, whether you had surgery or you had an emergency or something like that. because they are so in tune with genetic. So a lot of the times they'll send that consult, that genetics consult, into your room itself, which is what just happened to me, especially if you're in aortic center, stuff like that. So like Karen said, it's about talking to your doctors, whether it be your surgeon or your cardiologist, about what steps and what they can take.
Okay, do we have any other questions or comments? So the question, great question, can we ever put this disease behind us? I don't, it all depends because the disease is in many different places, right? So I look at me, this is my opinion, and then it's a he said, she said, and we'll hear what Greg's is. My personal opinion is if you're somebody with bicuspid valve and you have your valve replaced, I feel like then your disease might be behind you. I think that people who have this aortic aneurysmal disease, who have disease, I don't think it ever goes past you. I think it's written on the calendar, and then you find a way to live your life, and that's it. Everybody else has their own pace. So for some people it is paralyzing, and that's the saddest case for me, that people become so paralyzed to this that they're afraid to function and live. Am I jumping on a roller coaster? No. But I can still go to an amusement park, and there's things change and they become altered, and I look at that for me as if it is somewhat behind me. I can go through now many more days where it's behind me, it's not here, and then there'll be a day where I don't feel well, and all of a sudden it's right here. But that's just the way that it is. I think this isn't like some cancers for certain people where when you hit that 5-year mark of being cancer free, it's a huge milestone and celebration where sometimes you can breathe easier. I don't even think for those patients it's ever going to be behind them. I think it's always going to be just a little bit, maybe off to the peripheral, and you hope never brought back out front. I think it's a journey that's very different for each person.
I don't disagree. I would say, unfortunately, for those that dissected, you are managing a chronic condition, and how you view it and your mindset uh, will determine how much you can get away from it. But you are now managing a chronic situation. For certain intact aneurysm people, um, the watch and wait period can be horrible. It is horrible. I understand the anxiety that goes behind it. Um, but for a lot of them, it could be an isolated aneurysm, and it's addressed and behind them. Surgery happens and it's behind them. And for that, that's fantastic if you can get to it. But it's the one hard thing to say and make in a generalization when we talk about aortic disease as a whole, because there's so many different books in the library. There's so many different stories of us. So there's going to be people that are going to manage this for the remaining part of their life, to some extent, or at least side effects for medications or stuff like that. And then it becomes down to how do you address it with your mindset. And then there's going to be people that, hey, my aneurysm was addressed, or even in the dissection, there are dissection people that were very contained, very small area of the aorta was affected, and they might deal with some monitoring, but they don't really deal with any lasting effects from the dissection. They had the emergency, it was addressed, and now they move past that. So I think it really depends on the individual person. And then I think it comes down to what mindset you want to take into it will determine how freeing you are from this.
I can only equate it to having Crohn's disease. Colitis is curable. Crohn's disease is not curable. You can go into a remission type state, just like you can be stable with aortic disease. Even if you've had a dissection, you're monitored, you're considered stable. I look at the two of those as being very similar. I do not think about my Crohn's disease. I have been in remission now for 3 years. I don't even think. I don't even need to. It's the first time I've gone longer than a year to have a colonoscopy. So I don't even think about it at all. This is different for Greg and I because we are part of aortic hope. So we are entrenched in everybody's world, in their stories, in their fears, in their triumphs. So we never get to really step away from this at all. But if you look at it similarly, anxiety is just going to make things worse. It's going to make your blood pressure go higher, your heart rate go higher. So learning those mindfulness techniques that are so important can help diffuse a situation when maybe you don't feel well, you got a little ping or pang. Learning how to try to diffuse that so that you can keep moving forward and not have the anxiety and not think about it. And there is some truth to scanxiety. When you know your scan's coming up, everybody can get a little nervous. But once you hear you're stable, you should live your life. However, we have to be almost a little bit more in tune with our bodies, but you don't have to do that all day. And definitely don't get trapped in the what if this happens, what if that happens. That's just going to create the cycle again. And then you don't get to be free from it, like Greg just described. So hopefully that helps.
And I think it's important to note that for those of us that are online in the Facebook communities and the support groups, while Karen and I have been there for years and have made a wide variety of friends, you'll notice that people disappear. And it's not because it's bad. That's the little note to you that they have gone on to not worry about it constantly. Doesn't mean that they don't resurface occasionally when a scan comes up, or hey, I'm getting a little bit of anxiety. My anniversary is coming up. I always get kind of antsy at that point. You'll see them pop back in. But if you've been there as long as I've been, and I know Karen has been, we see names that are constantly new popping up on posts. You do not see names from the same people. And it's not because they're not around. I still follow them on Facebook and see their everyday posts. It's just they have gotten to a different aspect of their life where this does not control their thoughts 24/7. Doesn't mean that they don't have moments of anxiety. It just means that it is not the overwhelming controlling factor of their lives. And that's a very natural progression.
Okay. Any other comments, questions, thoughts, things? All right, everybody, more exciting information coming your way this week on our website as well as our Facebook page. We look forward to having you be part of the discussion next. We're actually doing this live next Tuesday, not Monday, because we will be on our way back from our trip to visit our friends with Aortic Bridge on the weekend. So we will see you here on Tuesday, and that is the 21st at 3:40 at 4. We'll post it. I don't know what time it is. Where am I? What time is it?
It's normally 3, but we're going to call temporary.
I think we're 3 next week. I think we're 3 next week for sure. We're always shooting for 3. But, you know, doctor's offices, we're just like you guys. Things happen. So, all right, Greg.
Okay. Good to see you, Karen. And
see you.
Thanks for all the questions and for everyone that joined us this week. And don't forget to like this video and subscribe to be notified about further events. So that's pretty much it. And we will see you soon. Bye, Karen.
Bye, Greg.